Good afternoon, everyone. It is my great pleasure to welcome you all to the second international webinar on the AccuBoost technology, and our guest lecturer today, Dr. David Wazer. For those of you who are not familiar with Dr. Wazer, he's recognized in the U.S. as one of the leading authorities on breast cancer treatment, and has rather impressive credentials. He's the director of the Lifespan Cancer Institute, professor and chairman, radiation oncologist in chief at both Rhode Island Hospital and Tufts Medical Center. As well, he's the editor-in-chief of the American Journal of Clinical Oncology, president emeritus of the American Brachytherapy Society, and enjoys a variety of editorial responsibilities. Today, we will join the presentation of Dr. Wazer in progress, which will begin with a video displaying the AccuBoost technology. If you're interested, you will be able to skip past this introductory demonstration of the technique to Dr. Wazer's presentation directly. The AccuBoost technology typically is begun with a counseling session between the radiation oncologist and the patient to
evaluate patients based on their suitability for AccuBoost, and I'll talk about that in the webinar in terms of the criteria that we use. A patient is brought into the treatment room and is positioned as she would be for a mammogram. She has the breast placed on the mammographic plates. There's a gentle compression of the breast. We don't need to compress the breast to the same extent as diagnostic mammogram is done. We don't want to have pain or discomfort, so it's a fairly gentle compression. Quick image is taken, and the digital radiograph is processed. And these images come up rather quickly. And the radiation oncologist then looks at this image, and you'll see on the image, we'll get into this a little bit more in the presentation, a coordinate grid, and that coordinate grid is used to select the position of the applicator, and the radiation oncologist selects the type and shape of the applicator that's to be positioned. Once that is done, the coordinates are given to the therapist, who sets the machine up for treatment delivery. And that's what's happening here. And then, as you see, there's a wide range of applicator sizes and shapes, and we'll talk about that in the webinar in terms of the selection. These are snapped into place on the compression plates above and below the breast. The applicator tubes are now connected to the HDR unit. The test cables are run, and then and then this process is repeated in the orthogonal axis. And again, as most part of my talk today will be on the application of AccuBoost for boost radiation. For typical boost treatment, we will only treat one axis on any given treatment day, and then the next treatment day we'll treat the other axis. For accelerated partial breast radiation, as I'll talk about, we do both axes on any given treatment day. So again, the process here is repeated. The targeting grid is evaluated. The applicator size, shape, and position is selected, and again, the process is repeated here with the applicators being snapped into place. And the patients are generally very comfortable during this time period. We ask them to hold position, which they are readily able to do. And as you can see, we do what we can to make the patient as comfortable as possible here for a period of about the total irradiation for a boost process takes about 17 to 20 minutes. So it's a relatively efficient process. And then the treatment coordinates, et cetera, all the relevant information is entered into the image file, and that is recorded into the record and verify system. So that is the procedure. I think that what I like about that video is I think it very accurately depicts what the daily process is, and it is a very, very straightforward process. So my talk today will be the clinical application of AccuBoost with a focus on a boost. I'll touch a little bit upon APBI, but my understanding is for most in the audience, the interest in AccuBoost relates mostly to boost application, which really is what AccuBoost was initially developed for. Next slide. So the system, as I've described, really consists of several pieces, and there's a novel technique for partial breast radiation in that it is non-invasive, consists of breast immobilization, and what I think is particularly special about AccuBoost is it's using a mammographic image guidance platform, which really is unique within radiation therapy technologies, at least I'm aware of, around breast cancer radiation. It uses this highly collimated photon emission using these tungsten applicators, and I'll get into the dosimetry in a second. Again, I think another unique advantage of AccuBoost. And of course, an iridium-192 source as a brachytherapy technique. Next slide. As shown in the video, the setup is pretty straightforward. Take a mammographic image. Overlaid on that image is a targeting grid. With the mammogram, we can pretty readily see where the post-op changes are in the breast. Often this is made very easy by the placement of surgical clips, but as I'll show in some images later, clips are not always necessary. You can generally see these post-op changes on mammogram quite readily. And then there are a series of various applicators that can be chosen for the individual size and shape of the lesion. Next slide. Treatment delivery, as has been shown, is just placing the applicator in the appropriate position on the compression plate, and then the HDR source traverses the applicator to generate this highly collimated photon beam. Next slide. And as mentioned, this process is repeated in orthogonal axis, and the dosimetric properties of AccuBoost are contingent upon this cumulative dose distribution at the center of the breast, or at the target center of the breast, resulting in a high dose distribution at target with relatively low dose to surrounding breast, and particularly to the skin. Next slide. Next slide. There's some unique aspects of the dosimetry of AccuBoost that I don't think are fully appreciated. I think people often assume that it's a very uniform dose at the target center, but in fact, this is brachytherapy, and there's some dose inhomogeneity at target. And I actually find this dose inhomogeneity is advantageous. And as we see the cumulative dose cloud from the two vectors, and we take a cross-section of that dose distribution, we see as we prescribe to the 100% ice dose line in the lower panel on the slide here, that there is a rise in the dose intensity as we move towards the edges of the applicator, and that inhomogeneity to the edges of the applicator can be as high as 30%. And you'll also see that the dose peak actually extends beyond the physical edges of the applicator by a few millimeters. And we find this actually very advantageous related to certain clinical circumstances, as I'll show in some slides in a few moments. Next slide. But a key feature of this is that as we look at the 100% isodose shell, in actually higher than 100%, extending beyond the physical edges of the applicator by about 5 to 7 millimeters. And we often take advantage of that when we're addressing certain complicated target volumes. Next slide. So through my career, I've always been very focused on what I view as the challenge of the boost in breast cancer radiation, and that is delivering the dose where it's needed, where, at least in the United States, sort of a simplistic thinking around what the target volume is for boost radiation being focused on the surgical excision cavity. But as I think we all realize, that is not always where the residual cancer is in the breast. And I think clearly it's desirable that we deliver that boost dose to the tissues at highest risk. Next slide. And when we look historically at how boost radiation has been practiced through most of the world, we have had a variety of different localization techniques explored over the years, although currently CT-based localization appears to be the dominant technique. But most of us using on-phos electrons to deliver the boost. Next slide. And apart from some of the localization issues associated with CT that I'll get into, just electrons themselves can be a challenge when delivering boost radiation to the breast, including the fact that there's what I call the fuzzy edge or uncertain penumbra along the edges of an electron beam. And we, as most of us prescribe to the 90% isodose line, that 90% isodose line is bowing inward at depth. That must be taken into account as we plan our PTV, our planning target volume. Next slide. And then coming back to how we plan, what is the image guidance platform from which we plan boost? We look at CT scan primarily, but if you ask a breast imaging specialist what is the worst way to look at the breast, they'll tell you with CT. It's a very inexact way to define a target tissue in the breast. Next slide. So as we look at this high-resolution fan beam image of the breast, I would ask, where is the tumor bed here? It gets lost in the normal breast parenchyma. Next slide. And it's often a significant amount of guesswork in defining, based on this just a CT image, what is the tumor bed that is to be boosted. Next slide. And this study that was done now about 10 years ago, one of my favorite studies from a group of my colleagues at Harvard, looked at several cases. These were all expert breast radiation oncologists, and they were given a series of cases. And the two examples here, one, the upper panel being the easy case, and the lower panel being the more difficult case. And you'll see these four expert breast radiation oncologists had a tough time agreeing what this target volume was, whether it was easy or hard. And I think it underscores the challenge that CT scanning presents in accurately defining tumor bed. Next slide. But all of this, I think, has clinical consequence in that the volume of breast being exposed to high dose for boost matters, at least with respect to toxicity. Next slide. And my experience in the United States is, I think, radiation oncologists generally accept the uncertainty associated with CT-based delineation of target volume, as well as their knowledge related to the fuzzy edge penumbra of an electron beam. And they often err on the side of going big with very large target volumes to ensure that all of this inherent error is taken into account. But there's clearly a cost to pay with this, and we've seen this, I think, based both in experience and in clinical randomized trial data. Next slide. That as we escalate the dose to the breast with boost, there's a consequence related to late cosmetic and functional toxicity, typically with breast fibrosis. Next slide. And just an example of this, there's an electron boost patient, the lateral portion of the breast, you see the hyperpigmentation, and I can tell you that there's just a great deal of subcutaneous fibrosis in this patient as well. Next slide. So AccuBoost really was designed to address multiple issues here. First and foremost, to look at a much more reliable breast-specific imaging technology for image guidance, and that is not CT scan, but mammography. And in setting up a patient on a mammographic platform, there are other advantages inherent in that because the setup inaccuracy is taken away. Breast motion is eliminated, patient motion is eliminated, and respiratory motion is no longer really a factor here. Next slide. And as we look at the dosimetric properties of AccuBoost versus electrons, and this is in the context of doing three-dimensional planning for both AccuBoost as compared to electrons. Next slide. We really saw something quite remarkable, and that is for the same degree of target coverage, exactly the same degree of target coverage, AccuBoost resulted in a PTV volume that was a third smaller than that achieved with electrons. So a significantly smaller volume of normal breast tissue being exposed to high dose for the same degree of target coverage with AccuBoost. Next slide.
Yeah, Dr. Wazer, just a note for you. We received a question related to dose homogeneity, and I'll just read this question to you. Dose homogeneity is an important predictor of cosmetic outcome in the breast. Has there been long-term data evaluating cosmesis in patients treated using this technique? Dose homogeneity, and it's just repeated.
Yes, a great question, and yes, and I'll show some of that data a little bit later in the presentation. And I agree, dose homogeneity matters, but when we look at small volume boosting techniques with brachytherapy, we're actually taking advantage of some dose inhomogeneity as part of the boosting procedure. I think AccuBoost has been very, has some advantages in that regard. And I'll get into that in a little bit more detail later in the talk. Next slide.
And a second question, what is the skin dose?
I'm also about to show that. Next slide. So as we look to the specific point, comparing AccuBoost to electrons, again, because we're using two separate vectors or two separate axes to treat, we're spreading that dose, that entry dose across the skin. The skin dose is actually significantly less with AccuBoost as compared to electrons, about a third of the maximum skin dose with AccuBoost as seen with electrons. And this, as I'll show you in some clinical data, really has had significant consequence in the patients that we've studied. So looking at these dosimetric advantages, we did a matched pair comparison of a large data cohort looking at electrons versus AccuBoost or non-invasive image-guided breast brachytherapy. Next slide. And what this analysis showed that AccuBoost significantly reduced grade 2 toxicity both acutely and for the subcutaneous late toxicity. So really this was very much in line with what we predicted from the dosimetric modeling studies. Next slide. But another big advantage that we have found with the use of AccuBoost is being much more selective in how we direct the boost dose to reduce the volume of tissue being exposed to high dose. Next slide. And, you know, this really is not a new concept in breast cancer management. If you actually ask your breast surgeons, they go to great lengths when they excise a tumor specimen to orient and ink the specimen to define where a closer positive margin may be. And in that orientation, if they find a medial margin that's closer positive and they're looking to do a re-excision, they don't go back and re-excise the entire excision cavity. They just go to that medial portion and excise that as a way to minimize the amount of surgical disruption that they do to the breast. Next slide. So this concept has been talked about now for some years in various forums, but actually I see has not really penetrated into common practice in radiation oncology. There's a paper back from 2009 from a group in the Netherlands. Next slide. And they point out that, you know, if we look at a tumor with a 1.5 centimeter rim as being the area at highest risk for containing residual cancer after excision. Next slide. But the typical surgical resection specimen will have the cancer eccentrically placed, not in the center of the excision specimen, but to the edge of the excision specimen. That's the clinical circumstance we typically encounter. Next slide. But the typical boost volume is being defined by that excision cavity. So we see a very large portion of the breast being exposed to high dose. Next slide. When the actual volume at risk is quite small. So it's really, I think, AccuBoost affords the opportunity to better define and better think about what this residual target volume really is, and then use the modality to direct that treatment to that limited portion of the breast. Next slide. So we now, as a matter of routine, use AccuBoost really to incorporate specimen orientation, identifying margin or margins at risk, and then really directing our boost only at those tissues that we deem to be at significant risk. Next slide. And so here's an example. This is a case where we see the clinical target volume being less than 1 centimeter from the pectoralis fascia, coming down very deep. Next slide. But when we actually look at the excision specimen, the deepest extent of the tumor is defined as being 2 centimeters away from that specimen edge at the pectoralis fascia. So really, that the pectoralis fascia is not at risk. It's the anterior edge on this specimen that was close at about 1 millimeter. Next slide. So what we've done is we weight the applicator placement not posteriorly but anteriorly, where we expect the greatest risk of residual disease burden to sit. So this is, again, with AccuBoost, I think a great advantage and a great application of the tool. Next slide. And a further advantage with AccuBoost is we can use that specimen information in conjunction with the preoperative mammogram. So we will often have that preoperative mammogram sitting up next to our therapy film, our image guidance film, that pathologic information all together, and really looking at that in toto, in full context, as we define where that target dose is going to go. Next slide. So I'd like to run through some sample cases just to give you a sense of how we use the technology on a day-to-day basis and where we see some of the advantages with it. First, when we look at eligibility in our breast conservation population, we do see that about 72% of all our cases are eligible for AccuBoost. And for those reasons, for ineligibility, patient discomfort with compression, really quite rare to see that. Inability to locate the tumor bed, also quite rare. Very posterior tumor location, rare, and very small breast size can be a challenge at times. Next slide. Our prescription dose with AccuBoost, and what I say is really the dose you would use with AccuBoost would be the same as if you're prescribing with electrons, and presumably you choose that dose based on your assessment of the underlying risk for residual disease. We began our experience using 2 gray per fraction for boost for 5 to 7 fractions. So we now, as we hypofractionate virtually all of our breast conservation whole breast irradiation, we now have migrated to hypofractionating the boost dose as well, and we typically do 2.67 gray per fraction every 3 to 5 fractions, or for 3 to 5 fractions. Next slide. So here's an example, pretty easy case with a nice cluster of defined clips. The surgeon was very kind to us here, defined it very well. And next slide. Very easy to position the applicator here. And again, using margin information, we weight this a little bit toward the nipple areolar complex. Next slide. As I noted earlier, having clips are nice but not always necessary. And next slide. And we have found with experience, and not much experience, but we now have a pretty good eye to identify where post-operative changes are on these image guidance films. So the clips advantageous, and you can even see in the right-hand panel, clips define have been left by the surgeon, but you can still see the post-operative change pretty readily even without the clips. So clips are not always necessary for targeting. Next slide. Where clips are present, but the target is difficult to delineate on CT scan. Next slide. And there you see on the right breast some clips, but just a lot of parenchymal imaging in the CT scan of the breast. Very, very hard to really accurately define where the tumor bed here is based purely on CT scan, despite the presence of clips. But we sit this patient up, gently compress her breast, and take an AccuBoost image. Next slide. And you see the target volume really comes together very nicely, and very easy to target this quite accurately. Next slide. Poor cardiac anatomy. Next slide. This is a circumstance where an electron plan was generated for this patient. And you see a significant amount of dose is being delivered to the anterior edge of the heart, and in particular right where the left anterior descending artery sits. This is clearly not an ideal circumstance, as we do our best to minimize cardiac irradiation. So once again, we sit this patient up and compress her breast. Next slide. And we're very readily able to target this deep tumor bed location in a large breast with 0 additional cardiac irradiation. Next slide. Sometimes we run into peculiar chest wall anatomy. Next slide. This is a patient with a pectus excavatum. This was not a boost case. This was actually, we did a monotherapy with APBI in this case. You can see if we were to try to approach this with conventional tangential external beam irradiation, the lung volume here would really be quite significant. Next For very deep tumor bed and a large breast. Next slide. In here, large tumor bed, a big breast. We looked at many tangents for breast coverage and just saw that there was just an enormous amount of normal breast being exposed. Next slide. On-FOSS electrons, the biggest electron beam we have here is a 22 MeV, and we weren't able to fully reach the full depth of this target volume. Next slide. Combination of electrons and photons, still unsatisfactory coverage, but once again, we sat this patient up, compressed her breast, took an AccuBoost image. Next slide. And target volume was very clear and very readily treated with AccuBoost. So this was a really great advantage that we see with this technology, particularly for women with large breasts and deeply seated tumor bed locations. Next slide. And this is that patient at 35 months. It's her right breast that had been treated, and you just see an outstanding cosmetic outcome. Next slide. One area that I have to say I've been so impressed with the results with AccuBoost has been in with patients with periareolar or subareolar tumor beds. And this is an area that throughout my career I've been very frustrated with the results that we've seen with appositional electrons. And here's a case that was treated with appositional electrons. And you see less than optimal cosmetic outcome, some scarring around the nipple with puckering of the nipple. But more importantly, I think from the patient's perspective, high dose of radiation to the nipple-areolar complex is not well tolerated. These patients are symptomatic for forever after that treatment. The nipple tends to be hypersensitive with scaling and irritation that just lasts forever. So this is an area for much of my career looking for better ways to boost in this very delicate location. So one of the early areas that we looked at with AccuBoost, next slide, was as we flashed the applicator across the surface of the breast, what would be the dosimetric implications of that? We did a lot of modeling with Monte Carlo to convince ourselves that, in fact, a high degree of homogeneity was still maintained as we flashed the applicator across the surface. And so we began to apply this clinically. And this is an example of a subareolar tumor bed. Next slide. And you can see on this image, there's a periareolar incision, and this tumor sat just below the nipple here. Next slide. This is the AccuBoost targeting film, and you can see the post-op changes just below the nipple. Next slide. And this is this patient 5 years after treatment with, she had a very high-risk circumstance, so we gave a very high dose booster radiation in addition to 50 gray whole breast. And truly, I have never seen a result this good with electrons around the nipple-areolar complex. Just extraordinary in terms of the lack of toxicity that we've seen. I often say that people, if there's no other reason to get AccuBoost, it is for these circumstances for subareolar location. Really, the results are just fantastic. Next slide. And when we looked at this experience, we've published numerous papers related to our user database, where we have a large user trial underway, and we've collected now over 500 patients from both academic and community practices. And one area that stood out for all of the users has been sort of this universal experience with subareolar tumor locations and really excellent cosmetic outcomes. So these are the data from the user base showing, next slide, that when there is a skin flash, which is subareolar location, actually the cosmetic outcome tends to be better than if we're seeing deeper applications of the system. Next slide. And you can keep going there, right? Next example is a deep clip on the chest wall. Next slide. This is a circumstance I frequently encounter with my surgeons. They tend to take their lumpectomy excisions right down to the pectoralis fascia. Even when it's not necessary, they'll go deep. So we will often see, we go back one. We often see these clips sitting right down on the pectoralis fascia. I often, some of my junior faculty will see this, they'll say, well, this is not an appropriate AccuBoost circumstance because the clips are too deep. You know, we're going to have trouble getting compression at that level. But our experience has been we always give it a try, sit them up and compress the breast. Next slide. And more often than not, we see the clips mobilize quite nicely. And it's, again, just a terrific way to boost at a deep location without having to use a very energetic electron beam. Next slide. A situation with a deep clip that's only partly visualized. Next slide. Here we see a cluster of clips that's off to the edge of the targeting film. Next slide. Typically what we do in this circumstance is just slightly reorient the gantry and make another attempt at compression, and more often than not, these clips jump right into view in the target, and it's really quite easy. Next slide. Inframammary fold location, again, another area that I think is very delicate to bring an electron beam in and often results in some less than ideal outcome related to toxicity in this location. But AccuBoost can quite effectively target at this depth. Next slide. In our practice, and I think throughout the United States, we're seeing an increasing use in the use of oncoplastic reconstruction as part of lumpectomy. So no longer the simple excision cavity, but often these very complicated surgeries. And defining the tumor bed after a surgery like this can really be a challenge. And it's something where we've communicated with our surgeons as they do their tumor excision and before they do this reconstruction, sort of to be as precise as possible in defining with surgical clips where the tumor sat. But even when they do that, next slide, we're often left with a situation like this, and you'll see on the left-hand panel sort of the complicated scar left on the breast related to the oncoplastic reconstruction. And in the image, the CT image, we see the scattering of clips, no clear post-op changes to guide us as to which clip and where the tumor bed sat. So if we were left to try to electron plan this patient, it would be a very large area of breast, or would it even be feasible to do an electron boost in a patient like this? But almost universally, what we find is we sit these patients up again, we compress them. Next slide. And the story really comes together very nicely. It really, as the surgeons have placed these clips in a way to define that tumor bed with the reconstruction, it is really meant to be done in an upright position, compressed, and you can see this target area quite nicely, and we're able to boost these patients very effectively. So once again, I think in this era of oncoplastic reconstruction, and this has really been an area of a lot of concern in the radiation oncology community, how do we boost these patients? I have to tell you, with AccuBoost, we just haven't found that to be a problem. Next slide. And when we've looked at the APBI or boost in the setting of cosmetic breast augmentation or implant reconstruction, often asked is, can you do AccuBoost with an implant in place? And here's a patient, this is an APBI case, but she had cosmetic reconstruction of the breast or cosmetic augmentation of the breast. Next slide. But we're really these cases are very easy to do with compression. The implant tends to move away very nicely, and we think it's a terrific way to minimize the amount of breast tissue being irradiated in the context of an implant. Next slide. What are the circumstances where we don't think AccuBoost is the most appropriate modality? And I think that's an important question, and I want to give a few examples here that I think summarize those circumstances where we just don't think AccuBoost is the best choice. Next slide. And almost exclusively, these relate to having the extreme peripheral position in the breast of the tumor bed. Next slide. So here's an example of an extreme inframammary fold of the breast, and as a consequence of the surgery, the scar was very tethered, stuck down to the pectoralis fascia. Just a very difficult area to get compression in both axes and to visualize this area. So again, electrons are not ideal, but probably a better choice in this circumstance. Next slide. Here's an extreme upper inner quadrant location in a small breast. It's just really difficult to get compression. And in this circumstance, the scar was, again, tethered right down to the pectoralis fascia. So it's just very hard to get compression. Next slide. Sometimes we will look at a case like this and say, gee, this is going to be a tough AccuBoost case, very large breast, extreme lateral position. Is this a case that would really, how practical is it to get the compression plates in this location? But, we'll often give it a try and see if we can make this work. And in fact, next slide, as we look at electrons in this patient, less than ideal in terms of defining the volume here. And next slide. So it turns out, even in that location, AccuBoost was not a bad choice. We were able to achieve reasonable compression and still define the tumor bed quite readily. Next slide. Next slide. And once again, there's a small breast, extreme upper outer quadrant location, and as you can see from this, it's just going to be very hard to get compression in both axes here. Next slide. Sometimes, even with mammography, you just can't visualize the target. Next slide is another case of very large breast. Next slide. This is the AccuBoost image, and there were no surgical clips. We could not find a post-op change that we could reliably image here, but I have to tell you, it was no easier on CT scan trying to define what the tumor bed was based to do electron planting. So just some cases are just a challenge. Next slide. And small breast with inframammary scar. Next slide. Once again, relatively small breast, difficult location to get compression. So the periphery of the breast can be a challenge. Next slide. And that's all I have. I'm just going to look over the questions. One question I think is a good one. What is the depth of treatment with these applicators? Is there a limit of breast size and thickness can be treated with this technique? Yes, excellent question. We really need to compress the breast to a separation of a maximum of about 8 centimeters. That's readily achievable for the vast majority of patients that we treat. But occasionally, with a very large breast at a difficult location, if you can't compress to 8 centimeters, then I would suggest that the other techniques should be used. As to applicator size, Ray, just refresh my memory, we have an 8 centimeter applicator, is that correct?
Yes, for round applicators, we have 4 through 8 centimeter diameter.
Right. So really, the target volume is limited by the applicator size, but really, there's a broad array of applicator sizes and shapes.
So for our entire audience, obviously we've reached the point where Dr. Wazer is able to take questions from you. You can either type them into the chat box, or you are welcome to turn your microphone on and ask the question directly if you like. But in anticipation, we did receive some questions offline. One question we had received related to patient population where breast size tends to be a little smaller, and whether or not if the target is not central to the breast, what the likelihood is to be able to treat those patients.
Well, I think, as I showed in some of the examples, I think a very small breast size with a peripheral tumor location, those are tough cases for AccuBoost. And truthfully, I think electrons are better. That's a circumstance. I think electrons are better.
So if it's not right at the periphery for a small breast, you would believe it to be a viable candidate?
Most probably, yeah. Again, it depends a little on the clinical circumstance, and I have to say, it's also, you accumulate some experience and skill with this, as with all techniques, where cases in our early days we may not have viewed as being practical to do with AccuBoost. We now feel pretty comfortable with it. So there is a learning curve.
And there was a question specifically on skin dose. Would you like to comment on the typical range of skin doses that you're seeing?
Well, again, it depends on the prescription dose that you're using, but typically the skin dose is about 40% of the prescription dose, and this is dependent. This is because of you have axis, and it's a cumulative dose at center with the distribution of the dose, the entry and exit dose throughout the breast. And the skin sees relatively little dose in that cumulative dose distribution.
Okay, and we just received a question. How do you verify the position pre-treatment?
Verify the position pre-treatment. Well, you have an image. So you're seeing the target on the image. You're applying the applicator to that position. In our early experience, and if we have any question on a given patient, we will repeat the image after treatment just to verify that there's been no patient movement. So, this is a image-guided procedure, and you see what you treat, and you treat what you see.
Very good. Do we have anyone that would like to offer any additional questions? Okay, well, Dr. Wazer, can't thank you enough for your time and efforts to prepare this presentation. For those of you attending, we have recorded this webinar. It'll be available within 1 to 2 days. For those interested, please reach out to your local rep, and we'll provide them the web address for you to be able to download the link and view the presentation.
Dr. Dev?
Yes.
I have a question. I just want to know that what is the maximum the tumor grid size that we can accommodate with this AccuBoost?
The maximum tumor size?
Yeah.
Well, again, the maximum applicator size, it's really driven by the maximum applicator size, and the largest applicator size is 8 centimeters.
Okay. Now, what is the maximum available size?
Ray, I'm going to ask you to answer that one. It is 8 centimeters, is my understanding.
8? Yeah, we have two shapes of applicators. A standard round applicator, the largest is 8 centimeters ID. I think typically, Dr. Wazer, you recommend a 0.5 centimeter margin on top of the.
It's a little hard to reduce to very simple guidance, but it really depends on the clinical circumstance and whether you're doing boost or partial monotherapy, partial breast radiation, in terms of what that margin is. But typically for a boost, we're looking at a PTV expansion of 1 centimeter.
Okay. And in any of the situations that we may need to use multiple applicators?
Yeah, it's a great question. So typically the shape that you're looking at on one view, on one axis, is different than the shape that you're looking at in the opposite axis. So typically, we will select different applicators for different axes because once again, you're treating what you're seeing on that axis. Yeah, we typically will mix applicators.
And other than this 4-field technique, like lateral and anterior, is there any other angulation is possible?
There is. Oh yes, and we'll often do that. You aren't fixed on certain angles related to the gantry setting. So if we're concerned about skin dose, we may vary that gantry position on a day-to-day basis. So no, you're not locked into just 0 degrees and 90 degrees. Any angle that you can see an image is fine.
Okay. And what is the approximate time that it takes, the treatment time? Because it varies with the activity that matters. But what is the average time?
The average time for boost is 17 minutes. And you're right, the actual, what the biggest determinant of that time is the age of your source.
Age of the, yeah, absolutely. Suppose if I have the source which is at the almost in the decayed position, decayed activity, and about to change it for a new source, in that time, in that activity, how much would be the treatment time? For example, in a HDR, we'll say 2 to 3 curie or something like that.
For a 2 to 3 curie source, you said?
2 to 3 curie of iridium source.
Yeah, it's probably, I'm estimating here, probably in the 24 to 25 minute time frame.
Okay, so will that will not be a discomfort for the patients to have this breast compressed for that much long time?
Again, we generally haven't found that to be a problem, and we're not compressing to the point of discomfort. We ask patients, we want to get as much compression as possible, but tell us where it hurts. And if it hurts, we back off. You do not need to compress to the point of discomfort.
Okay. Right. Thank you so much. Thank you.
Sure.
Thank you so much.
Okay. Another question for you, Dr. Wazer. Does the patient stay in the same position till the applicator well positions times are standard, or do you create and
the patient does stay in the same position. The process here is very quick. We're talking about maybe at most 5 minutes. And the other part of the question is the dwell position time standard. The dwell positions and the time. The dwell positions are fixed by the applicator. So the applicator determines the dwell positions. The time of irradiation is determined by the separation of the applicators. So that is a function of the plate compression that you're able to achieve for a given patient. The calculation algorithm is a very simple, straightforward one. It's essentially a read-off table that's part of the system that you get. So the calculation is very, very quick. once we have those parameters, applicator size, position, and plate separation, the calculation is done in 30 seconds. So it's a very quick process.
Yes, there was a question about the applicator sizes. I would just add, there are two styles of applicators. There's round, there's also a rounded D shape. And as to the largest possible field for those, we have one that is 6 centimeters on one axis by roughly 11 centimeters on the other. So there's two different shapes to match what you might be trying to target. Okay. Not hearing any other questions. Dr. Wazer, again, thank you for your time and energy to prepare this presentation. And again, for all of our attendees, we will make a link available if you'd like to view this again. So thank you all for attending.
Thank you all, and I just want to add, if you elect to get the AccuBoost unit, we would very much welcome your participation in our ongoing data registry and research collaboration. So if you have ideas or would like to participate in some of our clinical trials, we'd love to have you part of that. So I look forward to interacting with all of you in the future.
Thank you.
Very good. Thank you, Dr. Wazer.
Thank you.
And everyone, have a good day.
Bye-bye.
Bye-bye.
Wow.
Turn up. Complete. Excellent. Wonderful. Is that about the same?